This lecture will cover the pharmacotherapy of benign prostatic hyperplasia, or BPH. By the end of listening to today's lecture, I hope that you are able to explain why certain medications should be avoided in patients with BPH, compare and contrast alpha adrenergic antagonists and 5-alpha reductase inhibitors for BPH, and list common adverse effects of both of those two classes of drugs for BPH. Just a few things for you to think about. You will see these true or false questions again at the end of the lecture so you can assess baseline knowledge and then what you've learned throughout listening to the lecture. But watchful waiting is an acceptable option for treating BPH, true or false. Prazosin should be considered first line for treatment of BPH. Tamsulosin has a more specific mechanism of action on the prostate, and finasteride is a good option for men with small prostates. So which medications can cause irritative or obstructive voiding symptoms in our patients who have BPH? Obstructive symptoms result from failure of the bladder to empty urine when it is full, and irritative symptoms result from failure of the bladder to store urine until it's full, and that's a result of long-standing obstruction at the bladder neck. So those obstructive symptoms can be thought of as voiding symptoms, so things like decreased force of urine stream, hesitancy, straining with urination, terminal dribbling, and incomplete emptying. Those storage symptoms are things like nocturia, frequency of urination, urgency, dysuria, and urge incontinence. There are 4 classes of medications which can have negative effects on these symptoms. So androgens, such as testosterone or DHEA, these can stimulate prostate enlargement, which can make the problem worse. Sympathomimetics, or alpha agonists, things like phenylephrine, pseudoephedrine, and oxymetazoline. These can all stimulate contraction of prostatic and bladder neck smooth muscle. Anticholinergic agents, such as antihistamines, tricyclic antidepressants, phenothiazines. There's also some recent data to show that even the inhaled agents, such as tiotropium and ipratropium, can cause problems. These can block bladder muscle contraction, impairing bladder emptying. And then diuretics. Things like thiazide or loop diuretics, like hydrochlorothiazide or furosemide, can produce polyuria. Our goals for treatment of BPH. We want to decrease bladder outlet obstruction, decrease that pressure of the prostate on the urethra, reduce symptoms of BPH, decrease residual urine volume, reduce the incidence of urinary retention and renal insufficiency, and improve our patients' quality of life. It's very important that treatment is patient-specific. We need to assess with each patient how bothered they are by their urinary symptoms. Do they want to be treated, and is it safe for them to refrain from active treatment if that isn't what they want? Treatment is only required when patients are bothered by symptoms to the extent that their lifestyles are affected. For patients who have mild to moderate symptoms, we can think about watchful waiting. This is basically just close monitoring until symptoms progress. Patients have moderate symptoms, we do have 2 classes of pharmacologic treatment that we can offer them. 5-alpha adrenergic antagonists, or alpha blockers. These work to relax the prostate smooth muscle. And then 5-alpha reductase inhibitors. These interfere with testosterone stimulatory effect on prostate gland enlargement. For severe symptoms, we can consider surgical intervention. So for those who are more visual, this algorithm is kind of the picture of what we just talked through. So if a patient is diagnosed with BPH, they have mild symptoms, we can consider watchful waiting. If they have moderate to severe symptoms and no complications, we can then think about how large their prostate is. On patients with a prostate that's less than 30 grams, we can use an alpha blocker. Alpha blockers are really the mainstay of our therapies for BPH. If patients experience benefit with that alpha blocker, we can continue. If there is no response, we can consider surgery. If patients have a larger prostate, so anything larger than 30 grams, we can consider a 5-alpha reductase inhibitor. These are working to decrease the size of the prostate, which is why the prostate size becomes important. If they respond, great, we can continue. If there is no response, we can consider a combination of a 5-alpha reductase inhibitor and an alpha antagonist or surgery. If we choose to use the combination, if they respond, great, we can continue it. If not, surgery becomes an option. And for those patients who have severe BPH symptoms or complications of BPH, surgery becomes the best option for these patients. Behavioral modifications. The first two here will help to decrease nocturia. So counsel your patients to avoid large quantities of fluids after dinner, avoid before bed. Both caffeine and alcohol can cause urinary frequency, so that those should both be avoided. Can avoid medications which may worsen urinary symptoms. We also can consider toilet mapping. So if patients know the location of toilets when they're out and about, this can help to reduce some of the social anxiety associated with the disease. They can maintain a healthy weight. When patients are overweight, testosterone is converted to estrogen in fat tissue, and an alteration in that testosterone to estrogen ratio can contribute to the development of BPH. And then so for those patients who have mild symptoms, watchful waiting is an option. It can be used in patients with moderate symptoms as well, or whenever the patient chooses to avoid therapy, if they just want to be closely monitored. For watchful waiting, patients should be assessed at regular intervals, so typically every 3 to 6 months. As symptoms progress, you can consider drug therapy. During this watchful waiting phase, patients should be counseled on medications that can make symptoms worse and what they can avoid, and any behavioral modifications which may help to control symptoms. In patients who have moderate to severe symptoms and are interested in beginning therapy, alpha adrenergic blocking agents, or alpha blockers, are first-line therapy. These work to block alpha receptors in the bladder, neck, prostate, and peripheral vasculature. There are two different classes. There's the second generation alpha blockers and the third generation alpha blockers. Within the second generation alpha blocker class, we have terazosin, doxazosin, and alfuzosin, which can be useful in treating BPH. These are all considered equally effective. Patients experience an improvement in symptoms and improvements in urinary flow rates. These typically will take effect in several days to several weeks, and it really just depends on the titration schedule of the specific agent that you pick, and we'll talk through those in an upcoming slide. An adequate trial is considered to be 1 to 2 weeks of therapy once patients are at their full maintenance dose. These are extensively metabolized by the liver, so the dose does need to be decreased in patients who have liver impairment. They do not need to be dose reduced in patients who have renal impairment. Adverse effects. The biggest adverse effect here is hypotension. Patients can experience dizziness. They can experience first dose syncope. Patients should be counseled about this. They should be counseled to be very careful when they're changing positions. So when they're getting up from a seated or lying position, they may experience some hypotension or dizziness. Adverse effects are less common with doxazosin XL, the extended release formulation, and potentially alfuzosin as well. These drugs do need to be slowly up titrated, and that will help to reduce some of the hypotension and dizziness that can occur. Patients can also experience rhinitis and malaise, and this is because of an extension of that alpha blockade in the vasculature of the nasal mucosa and the CNS. Tolerance will often develop to this, and it rarely requires discontinuation. Patients should be educated, though, that this may occur. They don't want to use topical or oral decongestants because it can make their symptoms worse. And they would want to cautiously use antihistamines such as diphenhydramine because of their anticholinergic effects, which can also have effect on urinary symptoms. Patients can also experience ejaculation disorders with these. Because of their effects on blood pressure, it's best to dose these medications at bedtime. Drug-drug interactions. You'll notice that most of these are also antihypertensives, things that can lower blood pressure. We can have additive hypotension with diuretics and antihypertensives, as well as phosphodiesterase inhibitors. Many of these patients may also experience erectile dysfunction, so this is a relatively common combination of drugs for patients to be on. We do want to encourage patients that if they're taking an alpha blocker, that they space it away from their phosphodiesterase inhibitor, which is used for erectile dysfunction, by about 4 hours. These are also considered to be Beersless medications to be avoided in the elderly, primarily because of their effects on hypotension. So, closer look at the 3 drugs within this class: terazosin or Hytrin. This does need to be dose titrated up over several weeks. It's recommended that there be about 3 to 7 days between dosage changes when titrating up. If patients miss doses or are non-compliant with therapy, they do need to be retitrated again from the beginning. And this is considered if they miss more than 2 days of therapy. You want to reinitiate very cautiously, and then also think about that potential for first dose syncope again because it has been out of their system. Doxazosin or Cardurum is available as immediate release and extended release. The immediate release doses do need to be titrated up over a period of several weeks. The extended release formulation does not need to be titrated up that slowly, although you should still titrate it up over a period of several days to a week. Alfuzacin or uroxetrol. This is functionally uroselective, but it's not pharmacologically. We don't really understand why. However, it does not cross the blood-brain barrier, so there is less risk for central nervous effects such as somnolence. It does have a drug interaction with cytochrome P453A4 inhibitors such as ketoconazole, itraconazole, and ritonavir. It's contraindicated to be used with those agents. The next group of alpha blockers that we'll talk about are the 3rd generation alpha blockers. These are selective for the prostate. They selectively block alpha 1A receptors, which are highly concentrated in prostate tissue. This means that we have less peripheral vasodilation or hypotension concerns. However, their uroselectivity is dose related. So at higher doses, we may have an increased risk for some of these concerns. But at normal treatment doses for BPH, the risk of hypotension is significantly lower than with the 2nd generation agents. Drugs in this class include tamsulosin or silodosin. These drugs are also metabolized by the liver. Adverse reactions. There is a very low risk for peripherally mediated adverse drug reactions, so specifically that hypotension. Ejaculation disorders are the most common. However, these agents are typically relatively well tolerated. These are a good choice in patients who have well-controlled hypertension who are on agents other than alpha blockers, or for those patients in which titration would be more complicated. So if patients have some cognitive issues where they might not be able to remember how to titrate their drug therapy up to the maximum dose or the appropriate dose. These also can cause something called floppy iris syndrome. Alpha 1A receptors are also located in the iris dilator. As the iris dilator muscle relaxes, the iris can become flaccid, it can billow out, or become floppy, and this is a specific concern during cataract surgery. It's most common with tamsulosin, although it can also occur with silodosin. Tamsulosin has been around longer, so my guess is there's just more case reports with it with tamsulosin because we don't have as much data with silodosin because it's a newer agent. Patients do not need to hold their drug therapy prior to cataract surgery. However, they do need to make sure that their ophthalmologist is aware that they're taking these agents so they can make modifications to their surgical procedure. So to summarize the adverse effects that we can experience with adrenergic or alpha adrenergic antagonists or alpha blockers, hypotension is the biggest one. We want to start with the lowest effective dose, give doses at bedtime, and slowly up titrate at 0.5 to 1 week intervals, specifically with the immediate release doxazosin and terazosin. We can use tamsulosin, silodosin, extended release doxazosin, or alfuzosin to avoid this hypotension, and especially in patients who are on other antihypertensive agents. Rhinitis and malaise can occur. We need to educate the patient that this is a possibility and that tolerance will likely develop. And then retrograde ejaculation can occur as well. This is relatively common with these agents, but it is not harmful. Our second class of drugs for BPH are the 5-alpha reductase inhibitors. These are preferred in men who have moderate to severe BPH or who are at risk of developing complications. Medication options in this class include finasteride and dutasteride, and these work by reducing prostate size by inhibiting 5-alpha reductase, which converts testosterone to dihydrotestosterone. Dihydrotestosterone is the active androgen that stimulates prostate tissue growth. These will help to reduce the static factor. There is no difference in efficacy or side effects between these two agents. However, there is typically less improvement seen than with the alpha blockers, which is why the alpha blockers are typically the mainstay of therapy. One of the downsides of this class of medications is that they can take approximately 6 months to work. So we can't assess efficacy until 6 months. An adequate trial of drug therapy is considered to be 6 to 12 months. And this is a disadvantage for patients who have moderate to severe symptoms because they're not going to see efficacy immediately. It takes that extended period of time. Available products, dutasteride and finasteride. Dutasteride is available as Avodart as a single agent. It's also available as Jalin in combination with tamsulosin. And then finasteride is available under both the brand name Proscar and Propecia. Proscar is dosed 5 milligrams once a day for BPH. A lower dose of 1 milligram daily is used for male pattern hair loss. These drugs are hepatically metabolized, although there is no specific recommendation for a dose reduction. Adverse effects. These are primarily sexual in nature. Patients can experience decrease in libido, erectile dysfunction, ejaculation disorders, gynecomastia, and breast tenderness. We also do see an increase in serum testosterone by about 10 to 20%, although we don't know the clinical significance of this. These can decrease the PSA, the prostate-specific antigen. So it's very important that we're checking this at baseline. By getting a baseline PSA before starting these medications, we can then continue to use the PSA as a monitor, as a marker for prostate cancer. We also do want to, at minimum, annually check a repeat PSA, primarily looking for any type of increase monitoring for prostate cancer. These are contraindicated in pregnant females. They are a pregnancy category X. Pregnant females and females of childbearing age should not handle broken tablets. The whole tablets are coated, and those are okay for pregnant females to handle, but the broken tablets are not because that coating has been broken. They also should not be exposed to semen of men who are receiving 5-alpha reductase inhibitors because there have been drug levels detected in the semen. Exposure to these drugs by a pregnant female can cause feminization of a male fetus. Summary of adverse effects for the 5-alpha reductase inhibitors. These can cause gynecomastia. Educate the patient that it may be bothersome but not harmful. These can decrease libido. These can cause erectile dysfunction. They also can cause ejaculation disorders. Just a quick note on 5-alpha reductase inhibitors and prostate cancer. These do overall lower the risk of prostate cancer. However, they can increase the risk of more aggressive cancers. So they lower the risk of less aggressive cancers, but can increase the risk of more aggressive cancers. So this is something that you want to mention to your patients and make sure you're discussing pros and cons with your patients prior to starting these. Also very important to get that baseline PSA, and then any type of increase in PSA prostate cancer should be further work. So the take-home message: rule out conditions that may mimic BPH, weigh risk versus benefit when adding these agents. We do want to make sure we're continuing to monitor, so digital rectal exam and PSA. And any PSA increase while a patient is on a 5-alpha reductase inhibitor should be investigated, even if it remains within the normal range. So just a brief comparison of our alpha blockers and our 5-alpha reductase inhibitors. I'll let you read through this, but it will highlight mechanism of action, its effect on prostate size, efficacy, how frequently patients have to take it, etc. And then back to our true or false assessment questions. So watchful waiting is an acceptable option for treating BPH. This is true. Prazosin should be considered first line for the treatment of BPH. This is false. Prazosin is another second generation alpha blocker. However, because of its frequency of dosing, it is not recommended to be used in the treatment of BPH. Tamsulosin has a more specific mechanism of action on the prostate. This one is true. Tamsulosin works on those alpha 1A receptors, which are embedded within the prostate, so it has less peripheral side effects such as hypotension associated with it. And then finasteride is a good option for men with small prostates. This is false. Finasteride is a good option for men with larger prostates, as it will help to reduce prostate size.